Here is our guiding question for today. When we run a cluster randomized trial, how do we choose and interpret an economic analysis we can actually trust for decisions? By the end, we want you to look at a cluster trial's analytic strategy and be able to say, yes, this method respects the design, the costs, and the uncertainty, or no, this is shaky.
On this slide, we set the agenda. First, a short refresher on key health economic concepts: costs, quality-adjusted life years, incremental cost-effectiveness ratios, and cost-effectiveness acceptability curves. Second, we talk about what is special about cluster randomized trials, including correlated outcomes, unequal cluster sizes, and baseline imbalance. Third, we compare common analysis strategies. And finally, we finish with a practical guide you can use the next time you read, review, or design an economic evaluation in a cluster trial.
A quality-adjusted life year, or QALY, combines length and quality of life on a scale from 0, which is equivalent to death, to 1, which represents full health, and it can be measured using standardized tools like the EQ5D. The ICER is the extra cost divided by the extra effect when we move from control to a new strategy. Because ICERs can be unstable, we often plot a cost-effectiveness acceptability curve, or CEAC, which shows the chance that the new strategy is cost-effective across different willingness-to-pay thresholds. When the ICER is less than the willingness-to-pay threshold, or lambda, we consider the new treatment strategy cost-effective. In Canada, a willingness-to-pay threshold of $50,000 per QALY is often used, but there is no official threshold.
The cost-effectiveness plane is a helpful way to visualize the decision whether a new treatment is cost-effective. The horizontal axis shows the change in effectiveness. Moving right means the new treatment is more effective. Moving left means less effective. The vertical axis shows the change in cost. Up is more costly. Down is less costly.
Interventions in the southeast quadrant are more effective and less costly, so that is an easy yes for considering it cost-effective. We also call it a dominant strategy. The northwest quadrant is the opposite: worse outcomes at higher cost, so we should not adopt that strategy.
The southwest quadrant represents treatments that are less effective but also less costly. Here, the decision really depends on how much effectiveness we are willing to trade for those savings. A small loss in benefit might be acceptable if the cost reduction is substantial, but a large drop in benefit usually is not.
And finally, the northeast quadrant. Treatments here are more effective but also more costly. This is where the willingness-to-pay threshold comes in. If the extra benefit is large enough relative to its added cost, then the intervention may still be considered cost-effective. If not, it won't be. That sloped dashed line is the willingness-to-pay boundary, and it helps us determine which side of that decision the intervention falls on. Before we dive into the rest of the module, it helps to see real numbers based on analyses published by the Canadian Agency for Drugs and Technologies in Health. This slide shows a few Canadian examples where drugs or vaccines were evaluated using ICERs. Notice how the ICERs span a huge range, from cost savings per QALY for using remdesivir plus standard outpatient care versus outpatient care in high-risk, non-hospitalized adults with confirmed COVID-19, up to hundreds of thousands per QALY for prevention of respiratory syncytial virus in infants. The key point is that we are always weighing extra health gains against extra cost.
So what changes when the trial is cluster randomized?
Patients in the same cluster, such as a hospital or family practice, tend to be more alike in both costs and outcomes than patients from different clusters. That correlation, or cluster effect, means we have less independent information in a cluster trial than in an analysis where every patient is independent of one another. Ignoring this correlation usually makes confidence intervals too narrow, and economic decisions look more certain than they truly are. The other thing is that cluster sizes, or the number of individuals in a cluster, can vary significantly from one cluster to another. This further complicates both design and analysis.
Think about the data structure you might have. At the patient level, we have resource use, costs, and quality of life scores, and so on. At the cluster level, we also have features like site size, staffing patterns, and local policies.
Beyond patients being nested within clusters, we might also see clusters being nested within regions or health systems that might impose their own level of correlation. Good analyses respect these hierarchies when estimating incremental costs, effects, and their joint uncertainty.
Cluster randomization rarely gives a perfect balance at baseline, especially in cluster trials where we might only have a small number of clusters to randomize. In practice, we might see some sites have sicker or more complex patients, or historically higher costs. If we ignore these differences, we can misattribute pre-existing cost or effect gaps to the intervention.
So, a vital part of a good analysis is to adjust for key individual and cluster-level covariates, which usually improves precision and makes treatment comparisons fairer. In practice, that often means including baseline costs or utility, along with important prognostic factors, in whatever regression or multi-level model we use.
The other thing to keep in mind is that economic data are almost never perfectly complete. Costs can be missing because of incomplete billing data, linkages that failed, or patients moving to another region not covered in our data sets. Quality of life questionnaires are also easy to miss at clinic visits, especially in pragmatic trials where we might not have a research coordinator embedded at each site to collect this information.
So, analyzing complete cases can waste information and bias the ICER in different ways that we might not be able to anticipate. We often depend on methods like multiple imputation, inverse probability weighting, or joint models to help fill in missing data. But these methods must also respect the clustered structure of the data. We've talked about missing data in a previous module if you want a refresher.
When we combine costs and effects, we have several decision measures. We've already mentioned ICER, but in cluster trials, many analysts prefer incremental net monetary benefit, or INB, because it is easier to model. We calculate incremental net monetary benefit as delta effect times the willingness to pay threshold minus delta cost. If that number is positive, the intervention is considered cost-effective at that willingness to pay threshold. Negative value means the intervention is of poor value at that particular threshold, even if it improves outcomes slightly.
Now for the analysis toolbox. There are several ways to handle clustered economic data. First, we can average costs and effects within each cluster and compare those cluster means. Second, we can use individual-level mixed regression models with random effects or generalized estimating equations.
We can also fit joint models for cost and effect, such as seemingly unrelated regression or multivariate multi-level models. Finally, resampling approaches like the two-stage bootstrap methods help quantify uncertainty while preserving the cluster structure. There are also Bayesian hierarchical models for complex data structures or small CRTs, but these are beyond the scope of this session.
Cluster-level summary methods are the simplest conceptually. Step 1 is to compute the mean cost and mean effect for each cluster. Step 2 is to compare those means across treatment groups, possibly adjusting for cluster-level covariates where appropriate. The transparency of this method is attractive, especially when there are many patients per cluster. The downside is that we cannot easily adjust for individual-level covariates, and we may lose efficiency when cluster sizes vary a lot.
Mixed models are often the workhorse in practice and are most commonly used. They add random effects for clusters, which lets each cluster have its own baseline level, while still estimating a single overall treatment effect. This structure accounts for within-cluster correlation and reduces the risk of overstating precision.
The graphic on the slide shows this idea visually. Each group has its own intercept. Each line starts at a different height, but they all share the same slope. These models are flexible and can allow us to analyze costs, effects, or net benefit and adjust for patient and cluster-level covariates.
Generalized estimating equations, or GEE, provide population average estimates without using random effects. They focus on the average relationship across all clusters, rather than estimating a separate intercept for each one, as we saw in the previous slide.
The graphic on this slide shows what that means visually. Each cluster, represented as its own color, still has its own pattern. However, generalized estimating equations fit one single line through all the data points. That black line represents the population average effect, which is what generalized estimating equations are designed to estimate. This method uses a working correlation structure and robust standard errors to adjust for clustering, but with fewer than about 20 clusters, those robust standard errors can become unstable.
For economic outcomes, generalized estimating equations are typically used to model cost, effect, or net benefit separately, rather than modeling their joint distribution. This keeps the approach practical, though sometimes less efficient than multi-level modeling.
Sometimes we want to model costs and effects together, not in two unrelated models. On this slide, seemingly unrelated regression is shown with two panels, the cost equation on the left and the quality-adjusted life years equation on the right. Each panel has its own regression line and its own cloud of points.
The arrows help explain the key idea. Each arrow goes from the regression line to an individual point. That vertical distance is the residual, the part of observed cost or quality-adjusted life year not explained by the predictors. In seemingly unrelated regression, we estimate both equations at the same time and allow these residuals to be correlated across costs and utilities. In cluster trials, we usually add cluster-robust standard errors to introduce shared random effects when costs and utilities are strongly correlated.
The slide shows a simple two-stage bootstrap, without the shrinkage correction often used with fewer than 20 randomized clusters. In stage 1, we resample whole clusters with replacement, keeping the same number of clusters as in the trial. In stage 2, within each chosen cluster, we resample patients with replacement to rebuild a clustered bootstrap dataset.
On this slide, we've pulled everything together into a quick comparison of the main methods we've discussed. The first column lists the method. The middle column highlights situations where that method is generally a good choice for health economic evaluations. And the third column flags situations where it may be less suitable or needs extra caution. This is meant as a high-level decision aid, not a rigid set of rules. In practice, you'll still need to consider your specific trial design, sample size, and data structure before choosing an approach. A more detailed version of this table, with additional notes and examples, is available on our Pragmatic Trials training program website in the module description.
Let's circle back to our opening question. When we run a cluster randomized trial, how do we choose and interpret an economic analysis that we can actually trust for decisions?
A good place to start is with clarity of perspective and time horizon. The analysis should explicitly state whether it uses a health system or societal perspective, and whether the time horizon is long enough to capture meaningful differences in costs and outcomes.
Next, check that the economic measures actually match the trial's clinical aims. Costs should reflect the relevant resource use, and outcomes should be consistent with how benefit is being defined, whether that's quality-adjusted life years or something more specific.
With cluster trials, the methods must account for clustering, covariate imbalance, and missing data. Mixed models, GEE, or joint models are all possible, but the key is that their assumptions make sense for the research question.
The results should be presented in decision-relevant terms: incremental cost-effectiveness ratios, incremental net benefit, and cost-effectiveness acceptability curves that show uncertainty, not just point estimates.
And finally, transparency matters. Be sure to explain all assumptions and justify why the chosen methods are appropriate. Even then, economic conclusions should be interpreted cautiously, especially when sample sizes or cluster counts are small.
That's a wrap. Thanks for joining us for this module. If you found it helpful, please subscribe to the channel and hit the bell icon so you get notified when new content is posted.